So we're going to be looking at anti-anginals and calcium channel blockers this round. We're also going to be looking at nursing implications when we're giving all our anti-anginals. So let's get started. Okay, these are some calcium channel blockers that we give for chronic stable angina. We have chronic stable angina. So we've got diltiazem or cardizem we can see, but verapamil is one you'll see. These are medications you're going to see out there that are given, but just remember when you see those, it's most likely they're being given for a chronic stable angina. Calcium channel blockers do a lot of what everything else, all of our anti-anginals do. They are going to create vasodilation, but the calcium channel blockers are going to cause coronary artery vasodilation, and they're going to cause peripheral arterial vasodilation, and they're going to decrease the SVR, the systemic vascular resistance. So what that means is that when those peripheral arteries, that arterial system dilates, it's going to, if we have something that's resisting, it's just almost like what it sounds. If it's having to work against, and it is, if we can open that up, it's going to bring that workload down. It's going to bring it down. It's going to make it not as hard to get blood through and make the heart actually contract. It will reduce the workload of the heart. That is so important that we do. If anybody that has cardiac issues, we need to reduce the workload of the heart. It's going to decrease the myocardial oxygen demand, just like before. If we're beating a lot, if we're having to force something through, anything like that, it increases that oxygen demand. It increases the workload of the heart. And we need to bring that down so that we can have a smooth, get the oxygen and the nutrients to the heart and have a smooth actual contraction without having to use so much force to make it work. Dysrhythmias, it's used to treat dysrhythmias. It can depress or cause depression of the automaticity of the conduction through the sinoatrial and AV nodes. So we're going to actually, if you're having an atrial fib, we can give a calcium channel blocker, and that's going to bring that down. It's going to help with depressing that so that we're not getting anything really rapid. So let's look a little further. So indications, angina, of course, that's been the number one thing for all of them, hasn't it? And angina is what? Chest pain. We're having some chest pain, heart pain. Hypertension, we give calcium channel blockers because they will dilate, which means it's going to bring your blood pressure down. So we will give calcium channel blockers for hypertensive patients to help lower that blood pressure. Supraventricular tachycardia, very fast and rapid. We need to stop it. If the heart is beating this fast, can it perfuse? Can it fill? Can it get enough blood in there? It can't. So we need to get that rate way down. So calcium channel blockers will block that. Calcium can't get, and that's going to decrease the that heart rate. It's going to bring it down. Prince metal angina, we talked about that in the first video with nitroglycerin. So these are spasms that take place. So we can give calcium channel blockers to help with that. It is a short-term management of atrial fibrillation and flutter. So that it's not a long-term. So we're not going to sit and give calcium channel blockers for a long period of time, but to control the situation, we can use them. The physician can order them. Migraine headaches, Raynaud's disease, and sometimes we can have cerebral artery spasms associated with aneurysm rupture, and we can give calcium channel blockers to help with that. Contraindications, when do you not give it? Well, if there's a known drug allergy, we're not going to give that. That is any medication you give. If there is an allergy that is known, that is a known drug allergy, for that medication, then no, do not give it. For an acute MI, yes, second or third degree AV block. If it's an acute MI, we're not giving the calcium channel blocker. And second or third degree AV blocks, no, unless the patient has a pacemaker. What our concern is if we gave a calcium channel blocker to a second or third degree AV block, and for my students, we'll learn heart rhythms at another time. But just so you know what's happening, it's a slow beat. It's causing the heart is not, the electrical part of the heart is abnormal. And so we can have a very slow heart rate. So unless we have a pacemaker that if we drop that heart rate out, will pick up and fire for us and make the heart beat, we don't want to give calcium channel blockers to second or third degree AV blocks. And hypotension, of course, because if we have hypotension and we give calcium channel blockers, we give them for hypertension, meaning high blood pressure. If we have low blood pressure and we take a calcium channel blocker, it's only going to lower it further. So we need to be very careful looking at our blood pressure and monitoring these patients. They need to be on a monitor, and they need to be blood pressures being checked on a more regular basis. Adverse effects for calcium channel blockers. They can cause hypotension. We just talked about that. Palpitations, tachycardia, or bradycardia. So they can create issues with rhythms. But this is an interesting one, and I'm going to ding, ding, ding my students. First of all, you need to know it can cause hypotension and palpitations, tachycardia, and bradycardia. That's a given. But I want you to realize that it causes constipation. So if we have an elderly client, one of the biggest things for them is their concern about their bowel movements, correct? And constipation is prevalent in that age group. So if we already are prevalent to constipation and we start giving a patient calcium channel blockers, it is so vitally important that we inform them that it can cause further constipation, or actually start to give them a stool softener or something, increase fiber, do whatever we need to do, fluids, so that this client will not become further constipated. Nausea and dyspnea, of course, and there's some other adverse effects. These are some drugs. I just want you to look at them for my students, for you out there. If you need to see, if you're out there working and practicing in nursing, cardizem, Dillacor, Tiazac are also are the diltiazem medications. I'm struggling with words tonight, sorry. It's a very effective treatment for angina pectoris resulting from coronary insufficiency and hypertension. It's used in treatment of atrial fib and flutter, along with paroxysmal supraventricular tachycardia. So these drugs are what you might see if there is a patient that's having these issues. We usually have a patient that's in atrial fib or flutter. We can, a physician might order cardizem, you could see. Tiazac, I haven't seen that as much, but I've also, things change all the time. Norvasc is another, indicated for both angina and hypertension. So what it's going to do is stop the chest pain, bring down the blood pressure. But this is the thing, ding, 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 for my students. It's only available, Norvasc is only available for oral use. I'm going to say it one more time. Norvasc is only available for oral use. So that is something that you really need to understand and know, because when you're out there and you see these meds, we have a physician that writes an order, we have a pharmacy that fills that order, and there's a check, and then it gets to the nurse. But one more time, the nurse needs to check to make sure everything lines up before that medication's given. So Norvasc is only given orally. Okay, this is a really cute little picture thing that I found. Calcium channel blockers, they're very nice drugs, right? Verapamil, nifedipine, and diltiazem. Very nice drugs. That's how you can remember those three for calcium channel blockers. Their actions are going to decrease contractility, decrease conductivity of the heart, which decreases the demand for oxygen. Side effects, though, we're going to have hypotension or decreased blood pressure. Bradycardia is something that can happen. May precipitate an AV block. So if we're in any form of block, we don't want to give calcium channel blockers. I said that earlier, but I'm going to say it again so that we're sure we understand that. It says it can precipitate an AV block. So if we're in a block, a heart block, an AV heart block, we do not want to give calcium channel blockers. Headaches, abdominal discomfort, we can have constipation and nausea, and peripheral edema. So this is a brief kind of synopsis of calcium channel blockers, and I actually hope that helped. Now, I want to go into nursing implications of all of the anti-anginal drugs, and it'll break down as we go down to each section that I've had a video on. But before we administer or perform anything, we need to do a health history. We need to ask these patients, these clients, what are they on medicine-wise, what they take, have they had cardiac issues, are they hypertension, do they have any of these issues? Because we need to know before we give the medication. So your assessment and health history are vital, because if you don't know what's going on with your patient ahead of the game or before that you start to treat, you can cause more harm, and we don't want to do that. You want to always obtain a baseline vital signs, including respiratory patterns and rate. So we need to make sure that we know what our heart rate is, our respiratory rate, our blood pressure. If you have oxygen saturation, that would be great. But those things, those baseline vital signs, have to be made, because one thing we know, as different things can happen when we give these meds. And one of the main things is we're going to decrease the heart rate. So we're going to bring that heart rate down. We're going to decrease the blood pressure. We're going to bring that down. And we want to be very careful that we don't get a patient too low of a heart rate or a blood pressure. And of course, respiratory patterns are important. Assess for drug interactions. So before you give a medication, just make sure whatever they're taking might not be that won't be a problem when you give these medicines. Patients should report. So if you're giving this medicine, and I'm going to say this to my students, to make sure that you really look at this, because you want to be able to explain and teach the patient what they should report. What is something that's abnormal that you need to let us know is going on? Blurred vision, persistent headache. They get a headache. Now, some of these medicines can cause headaches, but if the headache never goes away, that's not a good thing. We need to know about it. Dry mouth, edema, fainting episodes. One of the things that I want you to understand is that when we give certain anti-anginals, we can cause orthostatic hypotension. And what that is if we move quickly, our blood pressure can drop drastically, causing us to pass out. So what we want a patient or client to do always is, if they're on any of these, any kind of medicine that's going to alter their blood pressure, to be honest, we need to be careful getting them up. You don't ever want to get anybody up too quickly. So you want to set them up on the side of the bed, let them pump their feet a little bit, let everything adjust before, and you need to be there in front of them or at their side, making sure they're not falling or passing out and falling onto the floor. Safety, safety, safety. I'm going to say this for all you nursing students: safety, safety, safety. So you want to make sure, and then once they stand up, you can assist, make sure they're up, they feel good, stay there for a few minutes. And then once they are okay, then it's okay to allow them to kind of move. If they feel faint, though, they need to let you know, and they need to sit down. You don't want anybody falling or passing out or hurting themselves. If they have a weight gain of 2 pounds in one day or 5 pounds in 1 week, that is something we need to know. Now, one thing about cardiac issues is, if you have a heart attack, if you have a heart that's just not working like it should, we're in some form of heart failure, we can have where we can't efficiently pump and do what we need to do. So if we're taking these medicines and they can cause peripheral edema, and there's things that can happen with our heart, we need to make sure that we don't have a weight gain of 2 pounds in one day or 5 pounds in 1 week. And I'm just going on record to say this for my students. If you have a patient that is in heart failure, they should weigh themselves every morning, same time, same scale, same outfit, whatever. Can't wear a big sweatsuit and tennis shoes one day, the next day wear a little nightgown. We need to have everything the same. Go get up in the morning, use the restroom, tell your clients to use the restroom. And then once they're done with that, to go ahead and weigh themselves and document that, because they're not going to remember. So get a little piece of paper in the bathroom, tape it on the mirror, tape it on the wall, and every day just jot the time, date, and what their weight is. And they need to check this. If they have a 2 pound in one day, something's wrong, or 5 pounds in 1 week, and they need to contact the physician immediately. Pulse rate less than 60 beats a minute. They are bradycardic if they are under 60. So if we get under 60, we need to let a physician know. If the heart gets too low, you can't maintain your blood pressure. You can't perfuse adequately. So we want to make sure that they don't get too low. Sometimes what happens is medicines have to be tweaked or fixed to meet the needs for that patient without harming them or hurting them. And so sometimes, unfortunately, they'll get a medicine and it will bring the heart rate too low, and then they can pass out, they can be hypotensive, they can have a lot of issues, and they won't perfuse if we're not careful. Excuse me. And dyspnea, difficulty breathing. So alcohol consumption and spending time in hot baths or whirlpools, let me move me out of your way. Hot tubs or saunas will result in vasodilation. So if we're in a hot tub, a whirlpool, a sauna, anything that's hot or warm, it's going to vasodilate us naturally. We're going to vasodilate. So if we drink alcohol, it's a vasodilator. So if we're doing any of these things, we have to be very careful when we give these medications, because what happens is then we can become, I went forward, I'm sorry. We can become super hypotensive and possibly faint, get hurt, will vasodilate out, feel weak, fall. Those are the things we need to be careful. So if they're on these medications, no alcohol consumption, and really not get into hot baths, whirlpools, hot tubs, or saunas, or to really limit their time in it and make sure someone's with them, because this is what can happen. You want to teach patients to change positions slowly to avoid the postural blood pressure changes, the orthostatic hypotension that I just talked about. So have them sit up on the edge of the bed for a few minutes, pump their feet up and down, and that will help with some blood flow, and let them adjust and then get up, but not jump right out of bed ready to go, because what's going to happen if they do that, they're going to hit the floor, and we don't want that. Encourage patients to keep a record of the anginal attacks, including precipitating factors, number of pills taken, and therapeutic effects. So when we're teaching our patient to get up and weigh themselves, we're telling them not to move too quickly to prevent orthostatic hypotension. We also want them to keep a record, so when they come in to talk with the physician on their next office visit, they can say, I had chest pain, and what led up to that? What was I doing? Well, every day I go take my dog for a walk and I have this angina. I'm starting to have angina. So we know he's exerting himself, or she, and it just starts to bring all of the dots together. It brings all of the pieces of the puzzle. And so we want them to write those things down. Nitroglycerin specific. So we're going to start to look at the specific anti-anginals. We've gone through some of these already. I'm going to say it again so that you hear it again, because it's always good. We want to always instruct patients never to chew or swallow the sublingual form of anything. If it's sublingual, it's to go under the tongue, sublingual. Instruct patients on proper technique and guidelines for taking sublingual nitroglycerin for anginal pain. Instruct that there might be a burning sensation felt with the sublingual forms indicates the drug is still potent. So when they put that little pill under their tongue there, it might burn a little bit. And that is just so the patient knows that's normal. And it's just that the drug is potent and that's what they're feeling. Instruct the patients to keep a fresh supply of sublingual medication on hand. It loses its potency in about 3 months after the bottle's been opened. We need to instruct the patient about that. I want to say it again, ding, ding. If you have a fresh bottle of nitroglycerin tablets, sublingual, and I've opened them up or you opened them up to take, on that date, 3 months, they most likely will have lost their potency. So what's a good habit to teach your patients is if they open that bottle, to take a Sharpie or something and write where they can see that the bottle's been opened so that they always know. And then when they look at that date, they can check their date and they know they're good. But they should always make sure that they're replacing that sublingual nitro. To preserve potencies, they need to be airtight. I talked about that, no moisture. They need to be in a dark glass bottle with a metal cap and no cotton filler. So the thing that I want to make sure you realize is that they shouldn't take that pill and put it into their little pill box. They shouldn't take that pill and put the nitroglycerin tablet and put it anywhere where light's going to hit it or break it down. It needs to stay in its original container, which is a dark little bottle with a metal cap, and we'll screw it on. No cotton filler. Instruct patients in proper application of nitrate topical ointments in transdermal forms. Rotate the site and remove the old patches. It is so important. Also, if you are putting these on as the nurse, wear gloves. You get that ointment on you, you are putting nitroglycerin or nitro paste right on you. If you're removing a patch, same thing. You're touching it, and it can actually, you're going to absorb it. So always put on your gloves. Don't ever do it without. Take it off, and then once it's off the area, put the clean one on, rotating the site, and then clean that skin gently and pat it dry. Always date, time, and initial the patches and the ointment that's on the paper that goes on the patient, so that we know when it was applied and it's not an old one. To reduce tolerance, the patient may be instructed to remove topical forms at bedtime and apply new ones in the morning, allowing a nitrate-free period. So patients and clients can get tolerant to this medication, nitroglycerin. And if that's the case, instead of increasing the dose, we instead just instruct the patients while they're resting, while they're in a rest state. We're not pushing for that oxygen demand and that workload of the heart. In a restful state, go ahead and take off the patch, no nitro on, and let the body be nitro free through the night. And when they get up, they can put the patch back on or the ointment back on. And that will help reset the body in those situations with tolerance. Instruct the patients to take as needed nitrates at the first hint of anginal pain. If they have nitroglycerin tablets and they start to have any little twinge or pain, they need to take it. They don't need to wait till the pain's so intense and then try to take it. Take it immediately. And then, of course, wait 5 minutes. If it hasn't gone away, call 911. And then go ahead and take that third dose. So let me go ahead and say it again. Take your first dose. If the pain if you have no relief, go ahead and call 911, take your second dose, and then you can take a third dose, no more than 3 doses in 15 minutes. Monitor your vital signs. It's so important. You need to take a blood pressure pretty frequently, Q15, Q30. Once they get a little more settled, you can maybe take it a little longer in there, but definitely watch the blood pressure, because if you bottom their blood pressure out, if you take their blood pressure too low, the patient can actually cardiac arrest and code, because with being super hypotensive, they're not going to perfuse. So it's so vitally important that we watch that blood pressure and the heart rate. If experiencing chest pain, the patient is taking sublingual nitro should lie down to prevent or decrease dizziness and fainting that may occur because of hypotension. So if they're experiencing chest pain and they're having to take their sublingual nitro, have them sit down or lay down. First of all, it's going to do two things. One, it's telling you right here, it's going to prevent them from falling out, dizzy, fainting because of hypotension. But also, too, it's going to decrease the workload of the heart. We're going to go to a restful state, lay down, try to relax, breathe, take that sublingual nitro. Let's decrease the workload of the heart, increasing oxygen and nutrient filled blood to go back into the heart so that we can perfuse adequately. Okay, here we go. Anginal pain occurs. This is what you need to do. Number one, stop your activity, sit or lie down and take a sublingual tablet immediately. If there's no relief in 5 minutes, so 5 minutes goes by, somebody needs to be looking at a clock. Call 911 immediately at that 5-minute mark so that EMS is on the way. And then take your second sublingual tablet. So if you have family members, friends, anybody there with you, take that second tablet as they're calling 911. If you're by yourself, go ahead and dial 911. As you're on the phone talking, you can stick the second sublingual down in there as soon as you're off the phone, or tell the 911 operator that you are going to be doing that. If there's no relief in 5 more minutes, you can take that third sublingual tablet. Do not drive yourself to the hospital. Wait for EMS to arrive. The reason is because if you become faint, hypotensive, or go into a dysrhythmia due to a heart attack, you would then crash. You can hurt or kill yourself, or hurt and kill someone else, an innocent bystander. So just take the sublingual, maximum 3 doses in 15 minutes. You've already called 911 and wait for EMS to arrive. They will have what it takes to take you to the next step of care and intervene. So don't try to drive yourself. That IV forms of nitroglycerin must be given with special non-PVC tubing and bags. We didn't talk about IV nitro in this class. We will next semester in my class, but I'm going to go ahead for everybody else out there and for my students just to kind of know there is specific nitro tubing that we use. It's special non-PVC tubing and bags. We use that purposefully. When you hang nitro, you're going to go get a nitro tubing, IV tubing to use. We use it only for nitroglycerin. So it's pretty easy that way. You want to discard parenteral solution that is blue, green, or dark red, of course, and follow specific manufacturer's instructions for IV administration. For my students, we're not talking about IV nitro right now, nitroglycerin. So, but I do want to say for others is that you always want to keep that bottle covered because it breaks down in light. You want to use specific nitro tubing, nitroglycerin IV tubing, and make sure that if it's any other color or anything like that, it's not used. Okay. Beta blockers. Patients taking beta blockers should monitor their pulse rates daily and report any rate lower than 60. Our worry is we're going to become bradycardic. When we become bradycardic, we can become faint, we can become diaphoretic, we can become hypotensive, we can have a lot of issues. If they have dizziness or fainting, we need to know because they could be super hypotensive and not aware. Just a little off note, I'll say I've had a lot of patients, elderly women especially, that have gone home on beta blockers post a cardiac event and come back in and their little faces are all bruised up where they've fallen because they have the orthostatic hypotension or they have dizziness and fainting. So we just want to make sure that we're very careful with these patients. Inform patients that these medications should never be abruptly discontinued. If you've been given a beta blocker or a calcium channel blocker or nitroglycerin to take on a regular basis, a long acting or something, you never abruptly discontinue, because what can happen is you're then going to just stop something abruptly, and then we can get real irritated again or have something, almost a rebound effect. So we want to be very, very careful. And inform patients that these medications are for long-term prevention of angina, not for immediate relief. So if I'm giving beta blockers, it's for long-term effect. It's not to give an immediate relief to angina. Nitroglycerin will do that, but the beta blocker is going to do other things. And we talked about that in the video. Calcium channel blockers, Ccbs. I love that. Constipation is a common problem. Instruct the patients to take inadequate fluids and eat high fiber foods. Now, the calcium channel blockers do about what all the others, beta blockers do and nitroglycerin does. So that's why we went ahead, the video says, or the slide I should say, says constipation is a common problem. That is something you should understand with calcium channel blockers. And an easy way to remember it is, you see the Ccb or calcium channel blockers, the C and all that, constipation, it's another C. It's another C. So Ccbs causes AC, which is constipation. Good thing to know. Anti-anginal drugs monitor for adverse reactions. Headache is big, lightheadedness, hypotension, dizziness. Notice I'm repeating myself over and over, but it's so important that this is driven home. Monitor for therapeutic effects, the relief of the angina, chest pain stops, decreased in blood pressure. If they're super hypertensive or we're hypertensive, we've brought that blood pressure down, or both. Sometimes you'll get one and not the other, but we need to monitor. Because once we get therapeutic, then we need to maintain. Lots of times you'll hear ICU nurses or other nurses out there say there's a sweet spot. It's a place where we know we can run medications and this patient's going to stay stable. That wraps it up for calcium channel blockers, and also for nursing implications and different things dealing with all of the anti-anginals. I hope this video helps, and I wish you the best.